Good morning, everyone. So we will start today's session, and today is a very special guest lecture. I think I would ask Dr. Vivek Saraswat, my senior colleague here, who is the chief of hepatology department, who was my colleague at SGPGI for more than 3 decades, to start the proceedings and introduce today's guest speaker also.
Thank you, Professor Kapoor. Good morning, everyone, and welcome to this session. We have the good fortune to have amidst us Professor Sandeep Nijhawan, Senior Professor and Head of the Department of Gastroenterology at the SMS Medical College in Jaipur. Sandeep has been a very old friend right since our AV2 days at All India Institute during our DM training program. And ever since we have kept in close touch. He has done a lot of pioneering work in endoscopy, in improvising and developing very ingenious and indigenous stents, devices for use in situations in GI endoscopy. Dr. Nijhawan is also the incoming president-elect of the Indian Society of Gastroenterology. With these few words, I'll request Sandeep to please take over and speak to us about the uses of stents in gastroenterology.
Yeah, thank you, Dr. Kapoor and Dr. Saraswat for such a kind introduction. And it's always a pleasure to be here at Mahatma Gandhi Medical College because of various reasons, actually. So as they requested me for online lecture, but I asked them that I'll come physically. And probably they have such a physical lecture after a very long time. Today's topic is stents in gastroenterology, where it can be used, what are the types. So let's go in detail of that. Actually, stents are not very new. Actually, it was first introduced around maybe 150 years ago when a solid pipe was pushed in a patient to palliate dysphagia and esophageal cancer in 1885. In 1980, Soindra published a case report for a transpeptide drainage by a plastic stent in a biliary obstruction. And then first use of stents in malignant esophageal stenosis was done in 1983. There are 3-4 locations where it is being commonly used, but there are other locations where they are being used as and when needed. So commonly they are being used for esophageal obstruction, bowel obstruction at other places like gastric outlet obstruction, colonic obstruction, as well as pancreatico-biliary obstruction, and other conditions also where these stents are very useful. That details I'll go in my subsequent slides. As far as stents descriptions are concerned, they can be plastic stents. Now, these plastic stents actually they are made up of either polyurethane or Teflon. Because of different shapes, they can be single or double pigtail. They can be straight. They can be, S-shaped, as and when the indications are. Then we have metallic stents. These are the newer stents. Maybe last 20-30 years we have been using them in various conditions, and they are uncovered, partially covered, or fully covered. Then we have biodegradable stents. These are actually made up of material which is being used by all surgeons for actually biodegradable sutures, and they are made. These biodegradable stents also can be made from that. The self-expandable metal stents, they are made up of nitinol. Nitinol actually is an alloy which is made up of nickel and titanium. It was first developed by Naval Ordnance Laboratory, US. That's why the full name is nitinol. It is super elastic alloy. It has got 2 key properties. One is actually shape memory. So actually, and super elasticity. That means actually you can compress it when you want to introduce, and it goes back to the shape, the normal shape for which it has been made. So it has got an excellent memory. So these 2 properties actually are being used for making metallic stents, and they are of various sizes, lengths and diameters. So they can be used for luminal obstruction at various places in the GI tract. In esophageal stenting, actually, it's basically railroading, which is important in wherever you want to do stenting. Railroading means initially you have to have a wire inside, and over the wire, the compressed stent goes, and then you actually deploy that, and because of the elasticity and a radial force, the stent actually opens. Esophageal stents are either self-expandable metal stent or self-expandable plastic stents. They are made of a polyester with covered with silicone. They are being used all plastic stents for benign esophageal diseases. Biodegradable stent, again the suture material is being used. Actually, it fully degrades in 8 to 12 weeks. So there's no need for a repeat procedure to remove these stents. They come in various sizes of 6 to 15 centimeter in length. The length is being decided by the length of the tumor and the free space of 2 centimeter on either side. So that is the total length which is being decided for esophageal stenting. The diameter actually ranges from 10 to 23 millimeter. And if you want to do stenting at the lower end, then maybe there are stents with the anti-reflux valve, which actually helps in decreasing the reflux, which can happen in patients with a stenting at the lower end. Now, various type of stents are there: uncovered, partially covered, fully covered, and plastic stents. The plastic stent, the indications are benign esophageal stricture. It's a temporary measure, but it's actually a little stiffer than the metal stents, so it is other way around, and a little complex in introduction since system is there, and there is a higher risk of migration because of the. I mean, it's a straight conduit, so it can migrate, and there may be a technical failure. Re-intervention may be required, and but there's no tissue ingrowth and low degree of tissue hyperplasia because of plastic. So these are the advantages of plastic stent. The uncovered stent, they have a low migration rate because they get embedded in the normal mucosa as well as tumor, but at the same time there's high degree of ingrowth of the tumor. So maybe that you require a re-intervention in these patients, and a re-stenting in a stent is the option. Partially covered, fully covered stents, they have low tissue ingrowth and overgrowth of the tissue, and they are easier to remove because there's no embedding of the tumor of the stems, but it has got a higher migration rate. With esophageal stenting, we have partially covered stent. That means the middle part is covered and the ends are uncovered. So it's both the purpose of uncovered and fully covered stent. So these are the fully covered stent. They are removable. There is a lasso which is seen on the third stent. When you actually pull by holding it, you actually squeeze out the stent and it can be removed. And as I've already told, there's no less of tumor ingrowths is there, and they're particularly used in patients who have got fistula, but the high migration rate of course occurs as compared to the uncovered stents. The partially covered, as I've already told, the ends are uncovered and the middle part is covered, so it prevents migration. So ideal stent, esophageal stent, is easy to deploy and it stays in place, less migration because of the uncovered ends. So it reduces tumor ingrowth because of the fully covered middle part, and it can be removed if so desired. The ideal stent should have all the features which are not present in every stent. Because if you use fully covered, then it has got some advantage. If you use fully uncovered, it has got some advantage. But partially covered serves majority of the purpose in these stenting. So what are the indications? Actually, indications normally the commonest indications are inoperable tumor and there is a high surgical risk, and you want to palliate the dysphagia. So this is the ideal indication. The malignant recurrence, that means patient who has had surgery in the past or radiochemotherapy, and then because of an inoperable condition, and gets a recurrence at that site, and then stenting is the only answer. The extrinsic esophageal compression, that can be because of primary or secondary mediastinal and lung tumors, which leads to actually compromise of the esophageal lumen, and that's the indication for palliation of dysphagia in these patients. Tracheoesophageal fistula may it be benign or malignant. This is the gold standard treatment because surgical treatment has its own morbidity and mortality. So this is actually endoscopic procedure. So it is a treatment choice in patients with TO fistulas. Esophageal perforation may be spontaneous or iatrogenic. Bourhaave syndrome may be post-procedural. You push in a fully covered stent and then you actually tide over the crisis. Then maybe after 10 to 12 weeks, you may remove the stent. The benign strictures, those which are refractory to balloon dilatation and are not surgically amenable, is an indication for stenting. And refractory bleeding esophageal varices, Denisella stent is a fully covered stent actually. And those patients were not responding to the conventional endoscopic treatment like ligation and injection therapy, and they continue to bleed and TIPS is not available. And these are patients, they are high risk candidates for surgery because of the underlying bad liver functions in cirrhotics, and then you can use a fully covered stent which actually compresses the bleeding varices, and maybe you can remove it after 2 weeks. Stents in benign esophageal stricture, those strictures, they are defined as they cannot be dilated to 14 size over 5 sessions at 2 weeks interval. So there are very many patients which come to this indication, but in our country, poor financial status is one of the, and then not consenting of these patients to the major surgery becomes the major indication for pushing in SEMS for the treatment. Recurrent strictures don't maintain the luminal diameter for 4 weeks after dilatation of at least 14 millimeter. So these are the indications where we can use a fully covered stent or a plastic stent which may be left for 6 to 8 weeks. Biodegradable stent, again, that's also a choice with the added advantage of maybe you may not require another endoscopic procedure to remove the stent after 6 to 8 weeks. Contraindications, a curable malignant esophageal stricture should not be stented actually. Ideal treatment should be surgery. And patient with a limited life expectancy, like somebody who is living for maybe 2-3 weeks, I mean, if you expect that, then maybe a SEMS may not be required. And strictures which are actually very proximal, that means within 2 centimeters of the upper sphincter, there is a high degree of chance of a tracheal compression of the vocal cords, and that may lead to acute disaster in these patients. So if it is less than 2 centimeters, there are stents which are coming with short flare. They can be used, but you have to be very precise in actually placing the upper end. Then there is a risk of airway compression in few of the conditions. There you may go ahead and do a tracheal stenting first, followed by esophageal stenting. And somebody who has undergone a recent chemo radiation now, these are the patients where there is a high degree of migration, high degree of perforation in these settings when you do an endoscopic procedure. So maybe you may wait for 3-4 weeks after the recent chemo radiation, then go ahead and do it. Then there are patients where actually you are doing an esophageal stenting, but they have an obstruction ahead. So the purpose of actually, bypassing one obstruction may not serve the purpose. So if there's an unaddressed other bowel obstruction, then it has to be actually tackled first, followed by esophageal stenting. And somebody with an ongoing sepsis or uncorrected coagulopathy is also a contraindication. So adverse events, actually, these are very common in all type of stentings. Migration, again, that's a common problem with a fully covered stent, and there are double stents actually. That's a solution they are called as Bumpy Stents. They are covered inside and uncovered outside, and they have bumps on the outer part. So that will lead to less of the migration. hyperplastic granulation tissue, again, if the ends are made up of plastic ends, that may be the solution where actually the degree of growth is less, the hyperplastic granulation tissue. So that may be the solution. And tumor ingrowth and overgrowth, again, that's a problem with all uncovered stents and drug-eluting stents and radiation-emitting stents. Actually, that decreases the tissue ingrowth and overgrowth. So that may be the solution. And pain nowadays, these stents actually they don't actually overcorrect, so the pain is less in these patients. But of course, if there is a tight stricture, there may be, and you are doing an oversized stenting, that will lead to extra pain. So you have to decide the size of diameter also before placing the stent. So this is how actually I've already told about this, that initially you bypass. We should have, normally we do it under fluoroscopic assistance, where we dilate the esophageal stricture malignant to the 9th size so that the endoscope goes ahead. Then we have 4 markings, one at G junction, the other one is at distal end of the tumor, then proximal end of tumor, and then the vocal cords. So if you want to place the stent, now you have to place a stent between the most proximal and most distal markers. These markers can be external or internal, but normally, I mean, it's easy to place the external markers, and they are midline markers. So even with the respiration, they hardly move. So that is the commonest marker we use. But you can use actually endoscopic markers as well by injecting small amount of contrast. So this is how actually stenting is done. This is the actually gold standard of placing the stent anywhere in the GI tract. And this is how after the placement the stent looks like. This is the stent which is actually across the pyloric opening. And gastroduodenal stents, again, a malignant gastric outlet obstruction is the indication because of the carcinoma of pancreas, stomach, or duodenum. Surgery is technically successful in up to 90%, but it has got a prolonged hospital stay with a little more high mortality and morbidity rates. Non-surgical treatment in a non-operable malignant condition is always better to palliate than by surgical means. And self-expendable metal stent, there was a review where almost 526 patients, the clinical success was around 90%. And oral intake, actually, all of the patients actually, it was a clinical success, and they go to actually a semi-liquid diet at least, and resolution of symptoms occur as early as 4 days. And so gastroduodenal stenting offers a good palliation and is safe and effective treatment option. Stent versus gastrointestinal for palliation of outlet obstruction and systemic review. If there is a short life expectancy, then stent placement should be ideal because of the favorable results and short hospital stay and less of morbidity in these patients. If you suspect a prolonged prognosis in these patients, of course, the patency rate of gastrointestinal is better than the stents. Now, type of stents being used in such situations are uncovered or fully covered. The uncovered are more flexible, more commonly used, and they even allow the bile flow because these actually stents may obstruct the papilla. So it should be an uncovered stent which we should use because you should not have, palliating the outlet obstruction but at the same time causing a biliary obstruction. So, and covered stents, they are less flexible and more migration rate and but advantage of less tumor ingrowth. You see, as you go ahead, then the esophagus, the stenting technically becomes a little more difficult. So, because of the actually the scope position which is not straight and then the deployment is difficult, technically difficult. So, we use actually colonoscope to deploy these stents, or we can use a ERCP scope for deployment of gastroduodenal stents. Contraindication, if there are multiple stenosis, of course, it doesn't serve the purpose actually of relieving obstruction of only one stenosis. And of course, stenosis is far ahead beyond the reach. Actually, you can actually, stent patients with a small intestinal obstruction because of the, recently we had a patient, inoperable tumor in the small intestine. But if you're actually endoscope, if you're, it was a D3 obstruction. So if your colonoscope reaches there, you can do the stenting. If there is a massive GI bleeding, again you cannot stent these patients because it's difficult to see the technique you are doing, the procedure you're doing. And there can be a suspicion of perforation, patient hemodynamically unstable, again it's a contraindication. So this is how actually colonic stent looks like after the deployment. And colonic stents first used in 1990 because of obstructed rectal cancer. Again, they can be of two types, either through the scope stents. So they require actually fluoroscopy and endoscopic assistance for deployment, or it can be over the wire stents, which could be passed over the wire and used only with fluoroscopic assistance. That means you initially go proximal to the obstruction, then you do a contrast study to define the length of the tumor, and then you pass in the wire, and over the wire you push in the stent and then deploy it under fluoroscopy so that both the ends are get flared up after the deployment. And only uncovered stents are FDA approved because of the high migration rate of even partially covered stents, colonic stents. So these are stents which are a little more broader than the other stents. So it depends on the lumen size you want to palliate. Again, the same procedure, you're finding that this is a colonic obstruction, and initially you see the obstruction, push in the wire, then push in the introduction system with a compressed stent inside, and then under fluoroscopic guidance you deploy the stent, and after deployment you can see the gush of the stool material coming out. Indication: malignant obstruction or a colorectal fistula. So palliation for that, actually pre-operatively, it is a bridge to surgery because of significant morbidity and mortality in acute obstruction of the surgery. So you can have a one-stage operation by doing a colonic stenting. So you tide over the crisis of acute obstruction. Maybe after 2-3 weeks, you can subject these patients to surgery. This is better than doing a colostomy and then subjecting these patients to a second surgery. Benign condition, uncovered SEMS can be used. Again, it can be removed during surgery with the diseased bowel. SEMS can be placed as far as the endoscope can be introduced. So it's not only, it's easier to have a distal obstruction and doing the stenting like in rectum and sigmoid, but as you go proximal and transverse or the ascending colon, the technique becomes a little more difficult. But if your endoscope is reaching there, under fluoroscopy guidance, you can actually deploy the stent. Contraindication: unstable patient, systemic toxicity is there, and intra-abdominal abscess is there. So that becomes a contraindication. Persistent coagulopathy, again, it's a contraindication. Distal rectal lesions less than 5 centimeters from the anal verge. Again, you can do stenting, but the problem is a high risk of pain, bleed, and tenesmus in post-deployment. So we really actually don't do in a very distal rectal obstruction. Again, similar kind of complication, that is hemorrhage, around 5%, it becomes self-limiting. So usually minor hemorrhage is there because of the technical procedure. Perforation, again, the incidence is around 5%. If there's a previous irradiation is there, or a balloon dilatation prior to stent insertion with a access of dilatation being done, access of manipulation of guide wires also, these are the actually risk factors for perforation. And late perforation risk occurs after the chemotherapy, so one has to be very actually cautious in these patients. And stent migration, again, 10%. It is more likely with the covered than the uncovered. Again, stent reobstruction can be there, and you can place stent in these conditions. Now we come to pancreatico-biliary stents. These are even, plastic stents are more commonly being used than the metallic stents because there are other indications also. Plastic stents, they can be straight or they can be single or double pigtail. Then these are various type of metal stents. The usual diameter is 1 centimeter. The length can be variable. They can be uncovered, they can be fully covered, or they can be partially covered. Indications, again, similar kind of indications. If there is an obstruction of the bile duct or pancreatic duct, may it be benign or malignant, and there can be leaks actually which can be dealt by doing stenting. So biliary leak, pancreatic leaks, we normally do stenting in these patients. Normally we do with plastic, but there are few patients where we actually go ahead and do a fully covered stenting in these patients. And to prevent post-ERCP pancreatitis, actually during ERCP, there is a 2 to 5% chance of getting pancreatitis, and especially in patients with previous history of pancreatitis with the previous procedure, small papilla, young patient, suspicion of SOD. All these are the risk factors, so we have to be more careful in these. And maybe we do a stenting of the pancreatic duct post-ERCP. So we have got plastic stents which are composed of polyethylene, polyurethane, or Teflon, PTFE, and these are easy to make. Actually, I used to make my own stents. Actually, then it becomes a little cheaper. You get the full length of the conduit we have, and then you can actually make your own flaps and own pigtails by heating them. So they're easy to make. They are cheaper nowadays, easily available, and stent diameter ranges from 5 to 12 French, and length from 1 to 18 centimeters. It all depends on the indication where and what length and what diameter you need. Self-expendable metal stents, these are also being commonly used in malignant obstructions, and the advantage being it has got a more stent diameter. That means it has a diameter of 10 millimeter. So there is increased patency duration. So re-intervention may not be required for recurrent obstructions. It has got a radial expansile force. So without sacrificing the flexibility, they are made up of nitinol, and they come in the length of 4 to 12 centimeter depending on the MRCP. You can decide the length of the stent required before subjecting these patients to ERCP, and the diameters of different types are available. It may range from 6 to 10 millimeter, but normally we use of 10 millimeter diameter. This is how the metallic stent looks like coming out of the papilla after the stenting. The indications are palliation of the biliary drainage. The indication for which we use it is to improve the jaundice. It is a controversial indication, but it is a commonest indication with a referral from oncologists who want to give chemotherapy with a bilirubin of less than 1. A little difficult to get bilirubin of less than 1 with a prolonged jaundice, but still we do it, and we wait for some time before giving chemotherapy to them. Intense pruritus, which actually deteriorates the quality of life, we palliate them by biliary drainage. Some anorexia gets improved after decreasing jaundice. Over quality of life, we also gets better after palliation of jaundice. Pre-operative biliary drainage, there are two schools of thoughts in these patients. There are few surgeons who want the bilirubin to be less than 12 before subjecting these patients, but there are few surgeons who actually tell us not to do any ERCP in these patients before because it may actually have some chemical inflammation because post stenting, as well as the chances of cholangitis because of stent. With a resectable tumor, the indications are somebody landing up with acute cholangitis, and is also an indication for stenting, or there is an expected delay of surgical intervention of more than 2 weeks. There we actually stent these patients temporarily with a plastic stent and then wait for the surgical intervention. Plastic stents, they are straight single pigtail or double pigtail, and patients with the limited prognosis, we go ahead and do plastic stenting, less than 12 weeks of survival. Uncovered metallic stent, normally we use uncovered stents in the mid and upper biliary obstructions, and it can be placed in any part of the biliary tree, even in the proximal biliary tree. Because of the uncovered part, both the biliary tree can be drained by a single stent. It has got a low migration rate, but difficult to remove these uncovered stents. The fully covered stents can be placed proximally but they should have fenestration in between. If it is post-cholecystectomy status, it is not a problem, but there is a theoretical um, indication of getting a cholecystitis post stenting. Of course, little higher migration rate. There's a high degree of sludge formation in a fully covered stent, but they can be removed later. So there's no significant difference in the risk of stent failure or adverse event as you compare uncovered with the covered stent. So the both can be used. Unresectable cancers, distal obstruction, survival more than 3 months, we use SEMS. Survival less than 3 months, you can go ahead and do plastic stent. Maybe stent exchanges can be done with the average patency of around 2 months. Hilar obstruction type 1 and 2, we go ahead and do ERCP, use uncovered stent. Uh, Bilateral, a little better, but you can drain a dominant system, that may work well. So dominant, normally because of the financial status of the patient also in a country like India, we actually drain the dominant system. If there is a hilar obstruction of type 3 or 4 block, normally we don't do ERCP in these patients because we can decide on MRCP and subject these patients to PTBD because the chances of technical failure, the chance of getting post-procedural cholangitis is more in spite of being a technical success of ERCP. Adverse event, again, similar kind of adverse events as with other stents. There can be stent occlusion because of ingrowth, overgrowth, and luminal impaction because of biliary sludge. In these patients, you can push in stent in a stent, metal stent in a metal stent, or you can push in a plastic stent. Stent migration occurs, so you can actually re-stent these patients. Cholecystitis with a fully covered stent across the cystic duct. So normally we decide according to the cystic duct insertion, we decide the length of the stent. Ascending cholangitis can happen if there is incomplete drainage, bleeding and perforation also can happen. Benign biliary strictures caused by post-surgical injury or chronic inflammatory states. Technical success of doing it is more than 90%. Clinical success 70 to 95% in post-operative strictures. The strictures related to chronic pancreatitis is more resistant to treatment because of ongoing inflammation which occurs because of primary disease. And multiple stents, we actually push as many stents as possible in the biliary tree at the first go, and we actually exchange these stents at 3 month interval for 12 months. So at 12 months, we tend to get the same diameter of common bile duct as we have a normal common bile duct diameter. In patients with a failure with plastic stents, we can go ahead and push in a fully covered stents in these patients, which dwell inside for 6 months and then you can remove it. Biliary stenting efficacy can be judged by performing ultrasound and doing LFT, and by that we decide whether we have to have more stents inside or it's a stent failure, then we have to go ahead and do other treatment. Bile leaks, post-op bile leaks successfully treated by doing stenting only or doing sphincterotomy plus stenting in 70 to 100% of patients, and it cannot be done in where there is a complete transaction or ligation of common bile duct or a common hepatic duct. Fully covered SEMs are the indication where actually plastic stent and sphincterotomy done together fail in preventing, in decreasing the leak. Bile duct stones, multiple stents. At times we are not able to clear at the first setting in ERCP. We push in the stent in these patients, keep stents temporarily. That reduces the number and size of stones because the accretion of these stones on the wall of the stents, and you do after few weeks you do the procedure and you may be able to remove the remaining part of the stones and the stent. Pancreatic strictures, single stricture in the head is ideal for treatment with the pancreatic stenting, and those strictures which are malignant, isolated in the tail, multiple strictures with chain of lake appearance, these are not amenable with pancreatic stenting. Here, procedure little technically difficult. We dilate the stricture by boogie dilatation normally, or we can use a Sohindra stent retriever or wherever there is a tight stricture. and then or we actually do a balloon dilatation, and then we place a stent for a longer time, like we do in biliary stenting. Nowadays, we have lumen opposing metal stents, which are coming into practice nowadays in patients with acute fluid collection, where they are very symptomatic. We can use it, or patient with born with infection, we use them. They come with various sizes. They are very small in size as far as the length is concerned. So they actually oppose the two lumens, and they can be pushed in anywhere where there are collections outside the lumen, and even gastrogynostomy we are doing with these stents. And these stents actually, again, the procedure is little similar, but to shortcut the time of procedure, we have the cutting, the coffee system actually combined with the stenting. We can use it by doing with ERCP or EUS scope. uh, so we can actually drain VON and PFC. It is superior to double pigtail stents because of the larger diameter, so more effective. And if the necrosis and debris is more inside the VON, you can go inside with a standard endoscope and you can remove those debris by direct endoscopy through the labs. Complications, again, similar kind. Bleeding is there, which can be torrential also in patients where lamb is being placed. Migration can happen on up to 20%, and if you actually delay a bit, there can be burring of the stents. Normally, we remove these stents in 3 weeks' time. If you carry along for a longer time, then they are difficult to remove. Perforation less by using EUS, stent occlusion can happen, but that can be used tackled by doing a balloon dilatation. So I will end up by saying that stenting of the GI tract, the pancreatobiliary tract, is always helpful to surgeons, and they can be a temporary measure, or they can be a good palliative measure where surgery may not be the choice. Thank you for your kind attention. Thank you.
Well, thank you very much, Dr. Sandeep. Well, I think in a very limited period of time, you've covered the entire gamut of plastic and metal stents in the GI tract, from the esophagus to the anal canal, including the biliary and the pancreatic systems. And all this goes to show the versatility and the variety of procedures that into which endoscopists are venturing and treating almost all the difficult and challenging scenarios. I'm sure there must be a lot of queries and questions from the audience. But just to set the ball rolling, I think I'll just take up a couple of points. We spoke about malignant gastric outlet obstruction, in which antroduodenal stents placed from the antrum of the stomach across the obstruction, which generally is in the post-bulbar area, D1, D2 junction, is a very good way of palliating. A couple of problems that come up is that since there is tumor there, tumor ingrowth, because these are all bare stents that are approved in this area, is one problem. Then if you have delayed or there has been, patients have been symptomatic for a week or 2 weeks, then you have the issue of malignant gastroparesis. That the stomach actually is very paretic, and despite placing the stent, you do not get a good drainage, and the patients cannot resume oral intake. Plus, also malignant gastroparesis, people have talked of, and there is no mechanical obstruction, but the system is widely dilated because of neurologic or nerve involvement. And I think you mentioned briefly about the new procedure of EUS guided GJ. Now, gastrojejunostomy, surgical gastrojejunostomy in a patient with disseminated disease is challenging and generally is not resorted to. We prefer the AD stent. But if you were to do an EUS guided GJ, I guess the issues of bleeding and ingrowth of the tumor may be minimized. So, any comments on that?
Yeah, actually, gastroparesis occurs concomitantly with these malignant tumors, and maybe after stenting also there may not be an exact palliation of all the symptoms of vomiting, early satiety, and things like that. In these patients, actually, maybe if you've already stented these patients, maybe addition of prokinetics may help in these patients. And If it doesn't help also, we can go across and push in a nasojejunal tube. And as you have rightly said, nowadays GJ is a better option in these patients where actually you can do it EUS guided. So you have a double balloon tube is there where actually you inflate both the balloons and push fluid inside. So as you actually drain the acute pancreatic fluid collection. Similarly, actually, you drain that fluid which is being obstructed by two balloons, and you place the lamps. So, short of surgery, it's a good procedure, and with a good results are there. And there and then on the endoscopy table, you can see the draining of fluid which occurs post procedure.
See, and another quite challenging area is hilar blocks. When you have especially multiple systems and any bare or covered metal stent, there is a limit. Maybe 2 or maximum 3 systems might be drained. But there are more systems than that. And also beyond the hilum, if you place any covered stent, you are actually blocking the other parts of the biliary system, so it is counterproductive. Recently, people have talked about the CAFI stent, which is a very short stent, 5 centimeters covered, which you can place across into a single segment and have the wires like the lasso threads hanging out into the duodenum from the papilla, so that retrieval is not a problem. So what are your thoughts on the
normally in type 3-4 blocks, we actually tend to avoid doing the ERCP in these patients because of the, you may be technically successful in these patients, but when you do the procedure, a little bit of, pushing the wire on the other side also can lead to infection. A little 2 or 3 drops of, contrast going to that side, you have to drain that system and become little technically difficult in type 3-4 blocks, how many to drain and how many stents to push. As far as CAFI stent is concerned, that's a good idea, and with a large lasso, you can remove it as and when required. And post-transplant, also these smaller stents are available to actually tackle the anastomotic strictures which are post-transplant.
I think in the chat box I can't really spot.
I have mentioned about how frequently a stent would be required for varices which you cannot control.
Actually, nowadays with the good endoscopic procedures we have, like we have procedure with us, like ligation we have. Now these procedures actually, they're very effective, and they can be bleed within 5 days. And those are patients where actually you have to intervene, and we inject even glue in esophageal varices also where they are not getting controlled. And if you have a facility of tips in these patients because of being a poor surgical candidate, that's the ideal choice in patients where a reintervention endoscopic treatment is also not helpful. And this stent actually is just like a conduit which is better than SP tube. Because in SP tube you have a traction, so you can actually erode the G junction, you can erode the nasal septum, you can erode the varices even, and you can keep it for a short while of 2 to 3 days, not more than that. But these stents, they can be kept for 2 weeks and then can be removed. They are easy to push it in. The only problem is the finances.
Expensive.
Yeah, they're expensive, around maybe more than 60,000 for a single stent.
So just to add to that, I think your question was how frequently do you need it?
Oh.
Well, it depends very much on the kind of bleeders you see. And in the last few months, we have had at least 3 patients who needed stents. So the situations are like if the patient has a very bad CTP meld and is not a candidate for TIPS and is not a candidate for any other rescue thing like transplant, then to achieve tamponade, you need to do that. Secondly, I think we can have quite refractory bleeding from post-EVL ulcers. In a poor liver function, CTPC patient, there are post-EVL ulcers, and once they have bled, then banding or ligation or even glue, etc., doesn't work. And people have tried, hemo spray and all that. That is not also very effective. But a mechanical tamponade allows you time, and 2 weeks' time is not just to stabilize the bleed. If there is minor deterioration of liver function, if that improves, you can think of alternative things like either BRTO or TIPS in these very difficult bleeders. So there is a definite place, and what Professor Nijhawan has mentioned, our major inhibition here is the cost. In fact, the last time we got it, I think we could get permission because about 80,000 was the estimated cost, and many patients are not able to afford. And in fact, you think whether if people are able to afford that, why not go in for a BRT or a TIPS, which may be more definitive? Because once there is high portal pressure and you have bought 10 days, 2 weeks of time, what do you do after that? Yeah. Even after removal of tips of Danicella stent, either rebleeding or poor liver function may persist. So those are the things, but it can be a life-saving device in given situations, especially when other options are available.
For esophageal stent, I think we mentioned that chemoradiotherapy recent is a problem. But then if we have an unresectable esophageal malignancy, the approach we would like to have is that keep a stent and then keep chemoradiotherapy. So is there a problem?
No, actually, what I was talking was like patient who has come with a history of getting 1 or 2 cycles of chemotherapy and then you put it in. Normally, we actually subject these patients to stenting, then we send for chemoradiotherapy. But maybe there is a time of 2-3 weeks in between, then you actually give. So that's a different story than somebody coming with a chemotherapy, radiotherapy, and then you give.
Anastomotic leaks, what is the recent evidence that it's a gastric or colorectal?
Yeah, anywhere the leak is there, it serves the purpose because we can localize the leak, we can see the leak, and we can actually bridge it with a fully covered stent. The only problem which occurs is the migration which can happen. If it's a tight stricture along, so there may not be a migration. Or otherwise, you can clip that area, the proximal end, so that the migration may not be there.
And what you mentioned regarding the esophageal stents, I think this practice of putting in a metal stent first to palliate, followed by chemoradiotherapy to palliate, to treat the tumor. What happens often is that thereafter, once you've treated the stricture, the stent migrates. So there's nothing to hold the stricture and the stent migrates, and that can be a problem retrieving it from the stomach.
By the time one has opened.
It has opened, but it will not have opened up so well that you don't need anything. Dysphagia may still persist and then it's relatively narrow, irregular. Retrieving the stent through that, especially if the lasso is not there, can be quite challenging. So those that problem remains. And I think if there is at all any delay, I think we recently had a patient in whom metal stent had been done, chemoradiotherapy was planned but was delayed. And when they went to another center for doing it, they repeated a PET scan. They said the tumor is dramatically increased. Apparently, the tumor had grown into the stent, and it was not tumor in the wall, but tumor in the stent. The stent serving as a scaffold, and the PET is picking up a long 6 centimeter segment of FGD avid. So I think that can create a lot of confusion.
In those situations, we actually put stent in stent. So there was a patient where we had put in 3 stents. So it was total conduit of the esophagus was made by stents.
Before doing a pancreatic duodectomy, when we request for pre-operative drainage, normally we place plastic, but recently there is evidence that short length stents. So what is the hypothesis? What is the philosophy? Why those short and they are covered? Short length stents?
Yeah, fully covered.
Fully covered. So what is the difference?
No, there is no difference. The only difference is the cost. If it is fully covered, then the chances of getting a chemical inflammation of the ducts is not there.
That's the only.
So and the embedding is less. So you can remove it, but if you are doing a surgery, you can removing it otherwise also. Yes. So, but it has got a larger patency of the stent. The plastic stents, you can go up to 12 French. Here you can go to 10 millimeter.
No. And also, I think it would depend on what the reason is for requesting for palliation. Quite often, a patient is malnourished. You want to improve his nutrition. Yeah. Short-term stenting for 2 to 4 weeks will not do it. And especially if you want to do adjuvant chemotherapy in a situation where you have biliary palliation and use adjuvant chemotherapy, you need palliation for weeks, where a metal stent will work better. Or if somebody is like in GBC, etc., you want to do embolization and O2N embolization for increasing the portion of the liver that of the functional liver remnant, then the palliation is going to be required for a longer period of time. Plastic stents will have cholangitis, and you will have repeated changes, and the purpose may be defeated. You may not be actually able to give chemoradiotherapy if a person is having cholangitis. So the metal stent may be a better option for giving effective palliation without obstruction for a longer duration of time.
I think that what I do understand what Dr. Kapoor is wanting to ask is, for a periampullary malignancies, we usually get a plastic stent placed. But there is gradually a trend that because of these plastic stents, this patient who has to wait for say 20 days, he may have second episode of cholangitis, third episode of cholangitis. To prevent that, some of the group plays a metallic stent. So what we used to do earlier was a normal metallic stent that was placed up to the mid CBD. But now there are new stents which have come up, which only open up the capillary region.
Right.
Is
Smaller
that
stents
like
are
a
there.
lamps? Is that a lamps or is it a?
No, it's a smaller stent of 4 size, 4
That is a
centimeter
short
size.
4 centimeter stent that is specifically used for periampullary. I think that was the question.
Yes.
Because what we used to do at SMS was we used to get a metallic stent placed and then subsequently removed during the surgery. But now there's a new trend that we have a smaller stent.
Small stents are.
The smaller the better, the shorter the optimal stenting strategy always is the shortest stent that does the job and without
More
the risk of
patency.
migration.
It has more
or restoring
patency.
patency.
Yeah, because we used to have many patients used to have cholangitis with a plastic stent.
Absolutely.
And they used to be rechanged, and then after a change, he has to again wait for 2 weeks.
Right.
And during this time, he may
Exactly.
have a metastasis. So prevent that, I think.
Usually for a periampullary tumor, there is no point pushing a 8 centimeter stent.
Yes.
Yes.
Because you are blocking the proximal system also.
And the cystic duct also may be a problem. The cystic may be low.
We need a removal, so that will come with the specimen.
That will come with the specimen. At the time of surgery, you have to remove. So if it is in the proximal part, retrieval will be difficult.
Shorter stents will have more efficacy.
More efficacy, then the cystic duct may be low. If you use too long a stent, you may obstruct the cystic duct.
Yeah.
And I think whatever you're saying is that the waiting list depends on the center to center. There are heavy, high volume centers where a person is stented today and his date for surgery comes up in 3 months. So during that time, the plastic stent is a good time of getting a chance of getting blocked. And what you're saying, cyclical cholangitis, remove a stent, put in a stent, or it is 8 months and an operable patient has become inoperable waiting for a surgery. So those issues are there. That's why metal stents have come.
Now I'll come to a controversial. 2 groups sitting together. Biliary stricture. Post-cholesterol benign biliary stricture. Stenting. Now, what you will prefer? Whether you will prefer multiple plastic stents vis-a-vis metallic stent?
With multiple plastic stents, if they are working, there is no point putting in a metal stent. Now, these multiple plastic stents, they have to be actually, upgraded. That means,
the size is maximum actually.
yeah. So if we are pushing 3 stents at first time, then after 3 months, it has to be increased in number of stents. Then you have to exchange those stents because they have to work. So it's not only, they get blocked also. So you remove the 3 stents and push in 5 stents. Then you actually upgrade. So you go ahead and do 4 to 5 sessions in 1 year. If that fails, then you take the use of metal stents. Otherwise, they are very useful. There was a study by Costa Magna where it has been compared with the surgical outcome. And it has been found that surgery was better.
That is the only
Then it depends how you use it.
The long-term outcome.
Then clinical success, how do you define a clinical success once you have placed a metallic plastic stent? You said it is having 70 to 90% if I remember it in your slide.
More than 95%.
Then what is that after removal of the stent, the patient has a directed system with a normal LFT alkaline phosphatase without symptoms, or with stent the patient is having a clinical success? So,
No, technical success means degree of.
Technical is fine.
Technically.
Clinical.
After the removal, the LFT should come down to normal. Alpha should not
And it will
change.
persist.
So that's exactly what. We haven't published our experience at SGPGI, but we have similar 90-95% success rate and 8 to 10 year follow-up, median follow-up in a cohort of about 30 patients after removal of all stents and no symptoms, normal LFT. And when the cholangiogram was done, we did it serially for a few patients up to 3 years or 4 years. Almost no difference between the upstream, strictured and downstream segments. So it's restoring essentially a normal bile duct and normal bile function, no symptomatic recurrence. So I think that is doable these days with these. The issue about plastic and metal that you mentioned and you raised first was that in the post-cholecystectomy situation, Generally, these are high strictures at the hilum. And if you wish to place a metal stent there, it is often what will happen is either you have to go into the intrahepatic system, or only a centimeter or two of your stent is actually in the stricture. Most of the stent is below the stricture, and there is a relatively higher rate of migration of such stents as the stricture opens up. So most people prefer plastic stents for post-cholecystectomy hilar strictures.
One thing I could not understand that something you told about Sohendra stent retriever for PD stricture dilatation.
No, it's basically Sohendra retriever is a screw. So it's basically a Teflon tubing, and there is a screw. So you actually, you screw the stricture.
Okay, so in the PD stricture, you just screw it.
It's very fibrotic. So it's not like
fibrotic.
It's not like Sohendra dilator. It doesn't have a stainless steel tip. The Sohendra stent retriever has a screwing tip. So if there is a migrated stent, you actually screw it and remove the stent. Same is being used to actually corrode the stricture.
To find your way through tough fibrotic strictures, the wire has gone across. Your thinnest dilator will not go across. So then to do that, you use a corkscrew movement, because there is a thread as you have at the tip of the thing. It's a metal thing. So if you're using a corkscrew thing, it grips the stricture and finds a way through even tough fibrotic strictures, benign or malignant. So that is something that has been used.
Yeah.
Similarly, I think you would have heard the use of these thermal devices which you use for puncturing, which you have at the tip, cauteries applied, and you burn your way through the stricture. These are short strictures, less than 10 millimeters, 8-10 millimeters. So cystotomes have been used to go across tough strictures.
I would have been happy if residents would have asked some questions. We are both gastroenterology and surgical gastroenterology and the access of questions from residents.
I have a question. You said in contraindication, very short, less than 3 to 4 weeks life expectancy, they are contraindicated. Stents are contraindicated. But in your indication, you said in a shorter life expectancy, how do you decide?
It's a subjective phenomenon.
Yeah.
So if somebody, is very sick, you expect that he may not live for two weeks. So there is no point subjecting him to endoscopic procedure. Somebody you expect like he will live for 2-3 months. So you give him some good quality of life for those 3 months. So use plastic stents. Somebody you think that they may live for maybe more than 3 months, 6 months, 8 months, then stents.
Now coming to the biliary structure. I am totally against, because it is against the pathophysiology of.
No, it is not. It is for the pathophysiology. You are restoring the normal passage. While you people are by diverting everything into the stomach. Not physiology.
Just listen to me. In our surgical literature, there is
This is for surgeons. This is not for plastic. You stent your surgical anastomosis, you will not have a problem.
One last question. In case of esophageal perforation with a normal esophageal lumen, how is stent going to help these patients?
No, actually, Urabe syndrome. No, somebody who has got acute perforation, he has come. Now, we immediately go inside, see the perforation, post-ecclesia dilation, see the perforation. So we have already got the wire inside, you push in the wire. Then you have largest flare of the stent, you push across the perforation. Then what you do is you clip the proximal end with the hemoclips to the mucosa, because otherwise it will migrate.
You have to anchor the
You have to anchor.
Some anchoring procedure has to be added to bridging the defect.
So largest possible size which the human will allow, and
so what I remember is there is a stent which is covered in the center and it is having a uncovered proximal end, which gets opened up.
Yeah, bigger flare.
The bigger upper flanges.
Similar type of stent used to come, which was devised for a post-sleeve gastrectomy. They used to have a lot of operation at the fundus, at the upper portion. So they used to have a long stent which will have a proximal dilated area which will open up into the esophagus, and the distal will go
beyond in every stent. Every esophageal stent with a larger flare. There's a special stent which comes. And there are few stents with a small flare. So high cervical tumor, small flares.
So what is the disadvantage of using a stent in the proximal esophageal stricture?
Cross residence.
Simple answer.
Vocal cords. No. Upper vocal cords.
Tracheal compression.
Wheezing will be in the
Laryngeal
when they have dyspnea.
Yeah, okay. I think we would close because we've already crossed 10. So once again, I would like to thank Dr. Sandeep Nijhawan for the accepting our request to deliver the lecture and also for coming here. I think this is the largest attendance, physical attendance that we have had in any session so far because I invited all colleagues from medical gastroenterology also of the faculty and president. Thank you, sir. Thank you once again. And I would request Dr. Chaubey to give a small gift to Dr. Thank you, everyone. Thank you, Avinash.
Thank you.